the housekeeping, so I'm going to try to do it. Let's see. So this session is being recorded. You'll see in the chat that there is a sign-in for continuing education credits for medical or nursing. So if you'll fill out that survey just to let us know who's here, that would be great, regardless of if you're searching for continuing education credits. Please make sure your microphones are on mute. And we will actually go ahead and get started with presentations. We have Dr. Mira will be presenting on COVID updates, and Tori Reeves and Amani Ransby will be presenting on the history of pandemics. So we can go ahead and get started with Dr. Mira.
Okay. Okay, can you see my presentation?
Yes.
Well, I think everybody knows about this. And my only comment is that here in this first photograph on the left, everybody was protecting the president, so he was lucky. Here he was not so lucky, although this was not the event that caused the infection apparently. But I think this serves as a good message to anybody who's doubting that masks do work. They do work. So my presentation today is about, it's going to be a little bit different. It's going to be about the pandemic in Africa, but I ran into this yesterday, which I think is extremely important. And it's a change of concepts of how we use our testing. So for clinical use, let's say you have a patient who comes in with symptoms of COVID-19. Yes, the best test to use is a molecular test because it has the highest sensitivity. But when you're doing surveillance, the game changes a little bit. Because for surveillance, you may not need a very high sensitive test, but what you do need is a test that you can use frequently and that it picks up people who are actually transmitting the virus. So in this graph, on the bottom line, the bottom dashed line, the one I'm marking here, is a patient who got exposed, becomes infectious in this shaded period right here. And on this dashed line, you're doing a molecular test. So let's say you do a molecular test here. Of course, it will be negative. The patient has not been exposed yet. But if you do not do a molecular test when the patient is infectious, you're going to miss that patient. And this could be an asymptomatic patient. But then if you, for whatever reason, tested this patient here, the test is positive, but the patient is not infectious anymore, and you are putting him on isolation for 10 days. So these tests are not really good for surveillance because you can have all these mistakes. First, you may miss it when they're infectious because you're not doing the test frequently. Why? Because it's expensive and most of these tests are send-outs. And second, if the test is positive, you're really isolating a patient that probably doesn't need to be isolated. On the other hand, if you look at the top line, if you're using an antigen test, which you can use more frequently because it's point of care, second, it's cheap enough, $5 or so, I've heard. So if you're testing for surveillance frequently, people, boom, you hit the patient here, and it's positive, and it's very likely that's infectious. Why? Because the antigen test is less sensitive, so it needs higher viral loads to pick up that patient. And if the patient has a viral load, high viral load, he's probably infectious. So this is a test with low analytic sensitivity, but high surveillance sensitivity. And I think this is critical to understand because as we move forward in this pandemic, we will need to test more people more frequently to make sure we are isolating those who test positive and do not become a source of infection. This was published in New England Journal of Medicine. I encourage you to, I just had like 5 minutes ago, I put this slide on this presentation. I didn't have time to put the reference, but if you go to New England Journal of Medicine, It's one of the latest articles that have been published. I do encourage you to read it. It's a very good read, and it's a short read. It's about a page and a half or so.
Dr. Mira, this is Christy. I just want to interrupt you for just 1 second. We have a lot of USET staff. Could you maybe just explain what sensitivity is very briefly?
Explain what? I'm sorry?
Sensitivity.
Oh, okay. So the sensitivity of a molecular test, best case scenario, is 80%. But the sensitivity of the antigen test compared to a molecular test is around 80%. So overall, you would say that a sensitivity, it's about 60% of a molecular test compared to the gold standard of being a patient with a diagnosis of COVID-19. But having said that, the sensitivity of the test during the infectious period is probably very close to the molecular test, because that's when the patient has the highest viral load. So there, it would be about 80% overall. Is that clear? Was that clear enough?
Yes.
Okay. So, you know, it's tough to, when you're saying percentages of sensitivities, because what is your gold standard? If your gold standard is a PCR test, then it's 80%, but 80% when the viral load is low. But if you're measuring it in the patient that is very infectious, then the sensitivity of the antigen test dramatically improves, because the viral load is so high that it becomes very comparable to the PCR test. But if your gold standard is a patient who's been diagnosed with COVID at any point in time, then sensitivities drop, because it'll depend on what part of that time period the patient's in when you're testing them, and the viral load may change according to time. Anyways, I hope I didn't confuse you more than I should. But if you read the article, it's pretty clear, and I'm sure you will find it very pleasing. Okay, so what I'm going to cover today is the question: why is the pandemic so benign in Africa? So this map is from WHO. The intensity of the blue color shows the higher the intensity, the higher the number of cases reported of COVID-19. And you can see that North America, Europe, and some Asian countries have very high density of blue. But when you look at Africa, it's very light blue. And the first reaction is, well, they're probably not testing enough. They don't report enough information, etc. Because that's kind of a prejudice response that we all have. But you will find out soon that that is not true. So millions of COVID-19 deaths were predicted in Africa by experts. Why? Because of the poverty, the lack of health care in many areas, etc. But 4 months after the pandemic started in Africa, that has not been true. So how do we explain that? So is it lack of reliable reporting and death registration? Did they not intervene with lockdown measures soon enough, or did they do that better? Does demographic features matter? Social, cultural aspects? Are environmental exposures different in Africa than in non-African countries? How about genetics? Genetics of the virus or genetics of the people, are they different? And also the immune system. So we're going to cover and try to answer some of these questions. So yes, Africa has a weak health system in the sense of how much money per capita is invested on a yearly basis. And you can see that it's less than $50 a year per African in most West African countries, compared to $2,500 per year in Europe and United States countries and the US countries. And if you actually go take a deeper dive, when you look at private health insurance, it's about $8,000 a year that we pay for our health. But this is just an average of the country. Population densities. You would think, well, Africa may not have such dense populations. It's a big country, a lot of rural areas. But there are cities that have higher density than many Western cities. Dakar, Abidjan, Lagos have 12, 11, 13,000 people per square kilometer, compared to New York, which has 7,000 people per square kilometer. That does not seem to be the answer. Poverty would explain that you have more COVID, but actually they're having less COVID. And unhygienic conditions, you'd also think, well, you may have more transmission of infections, but that doesn't seem to be the answer either. Although, yes, it is a poor country, and yes, they live under more unhygienic conditions compared to Western countries. So let's look at the cases. When you look at cases and deaths, this is cases and the right is deaths. You can see that Africa has much less cases compared to America and Europe, and it's close to most Asian countries, so it's low. And when you look at death rates are also very low compared to Europe and the United States. And this is WHO data. So the first reaction that we have is, okay, they're probably not testing enough and that's why they have less reporting, but the answer is no. When you look at testing in African countries per number of cases reported, so this graph here shows you there's different lines or different African countries. So for example, if you have 100 cases, how many tests have they done? And you can cross the line here in this country. For every 100 cases, they have over 150 or 200 tests done. But when you look at the European and American countries, the other countries, it's very similar. Actually, Africans have done more tests per diagnosed cases than we have. So worst case scenario, it's the same. Best case scenario, the Africans did a little bit better. So many African countries implemented testing early in their pandemic, and there's more tests per cases were carried out compared to other countries, if you take into account that you're doing it at the same phase of the pandemic compared to when it started. So what the Africans did is they implemented very early, much earlier than the rest of the world, travel restrictions, curfews, and school closures. When they detected the first case, or even after they even had a case. And these early responses may have resulted in fewer imported cases and reduced transmission, and that allowed a system that does not have a lot of money for healthcare, but probably uses it very appropriately. So they were able to set up their diagnosis of cases correctly. And very importantly, I really want to emphasize this. Africa is very experienced in managing in contact tracing. Why? Because they have Ebola, they've had Lassa fever, they've had a lot of other highly transmissible diseases in which they've ramped up their public health infrastructure. So when COVID came, I mean, for them, it was a little bit simpler than Ebola. And they were able to implement all these public health interventions early and properly. They had the resources to do that. So when we go and see when these measures were implemented, and you compare the African continent in blue with other continents, and you look at days after they had the first case, they had much earlier and intense implementation of the lockdown measures than any other continent did. So kudos for the Africans. Okay, so let's go to other factors. Does the age of the population matter? Is the virus genetically different? I mean, is it a less virulent or less transmissible virus? Are the genetics of the people different? How about the immune response? Is it different in Africans compared to others? Or within the African people, are there groups of Africans that have a different immune response? So age is a difference. So the African population is the younger population. And we all know that the most affected by death rates are the older people. So if you look at this graph, it's, you can see that if you put your line cut off here, the majority of the patients that have been infected have been less than 50 years old. And that does have an impact on decreasing mortality. Now, we still don't have good aggregate data on age-specific death rates for Africa, and that is needed so we can see if the lower mortality is just due to lower number of older individuals being affected, or if older Africans have less mortality than non-older Africans. I'm sorry, non-African older people. So we don't know that part of the equation yet. But age, it does matter. How about the genetics of the virus? Well, there were on this paper from Science that I'm referencing here, they did all the phylogenetic analysis of the viruses, and the answer is no. The virus that's circulating in Africa is basically the same virus that's circulating everywhere else. That doesn't explain lower transmission or lower mortality. How about genetics of the African population? Well, there have not been many studies done, but if you think that African Americans fare really bad with COVID, you would expect that if there was some African genetics that would be protective against acquisition of the virus or protective against mitigating that inflammatory response, we would see that in the African Americans in the US, and we have not. So that's not a final answer, but it is a hint that probably the genetics in the people are not very different in regards to response to this virus. Now, immunity, there might be some differences here. So it is important for us to all understand that if your immune response suppresses the viral infection early enough, you will have you're bound to have a better outcome. Or if your immune response is not excessive, so you don't get that cytokine storm or whatever is causing that flare of your immune response at day 7 or 8 after you get infected, you should also fare better because you will not get the bad ARDS. So what it is known is that people who have frequent or recurrent respiratory infections, specifically other coronavirus infections, probably fare better from COVID-19 infection. Why? Because your immune system is able to produce antibodies that may cross-react with COVID-19, and even your T cells that have been exposed to other coronaviruses may be primed. When I say maybe, there's experimental studies that prove this. We still don't have the final data. But we know that individuals who've been infected with coronaviruses, non-COVID-19, prime their T cells, and those T cells respond earlier and better when they are exposed to coronavirus SARS-CoV-2. The other important thing is that Africans are exposed to a lot of other diseases that non-Western countries are not. So HIV is worldwide, but the prevalence in Africa is very high. Tuberculosis is worldwide, but the prevalence in Africa is very high. Malaria is extremely high in Africa, and other parasites, schistosomiasis and other ailments are very common in Africa. And I'll show you a slide after this one that shows how being infected with a parasite, for example, Schistosoma mansoni, primes your immune system and generates cells called virtual memory T cells that can rapidly respond to other antigens, not necessarily the parasite, including respiratory viruses. Okay, so let me show you that. So this is a parasite, the Schistosoma mansoni, that infects an individual and goes to their spleen or lymph nodes, but this is the spleen. And while the T cells and the lymph nodes are responding to that parasite, there is production of interleukin-4, and that interleukin-4 primes other virtual memory CD8 cells that they are ready to respond against a viral infection in the lung. Although they were not exposed to this virus ever, they were exposed to this parasite, but they have characteristics that make them capable of fighting this virus. So in summary, individuals who've been exposed to multiple infections, especially early in life, parasites or other viruses like other coronaviruses frequently, they may have a better immune system to respond to these infections. And we know that in the African communities, they do have a lot of exposures to all these infections. But the other important thing is that this early and chronic exposure to pathogens it's activating your immune system very frequently, right? And so your immune system adapts so it doesn't cause an exaggerated response. Because if you would have like an exaggerated response every time you go in front of an antigen, you would have ARDS, early in life and die. So, maybe it's evolution. So these individuals that are being constantly exposed to all these infections can regulate their immune response much better, in the sense that it doesn't become exaggerated. So the ability to prevent excessive inflammation could be a critical parameter that is associated with COVID-19 outcome. And the data suggests that alveolar macrophages from African individuals with high exposure to pathogens are less pro-inflammatory than the same macrophages in non-African individuals who have not undergone all this, chronic exposure to environmental antigens. So in conclusion, there are immunologic responses, not only in Africans versus Europeans, but also among Africans with high and low exposure to microorganisms and parasites. What this means is that they studied Africans' immune responses compared to non-Africans, and they are different. But within the African communities, people who are on the higher socioeconomic end are less exposed to these antigens and have an immune response similar to Westerners. But the majority who are in the low socioeconomic classes have a much more regulated immune response. And this has been well studied. So there are differences in opinion about whether the patterns of SARS-CoV-2 spread different in Africa compared to the US. But what it is very clear is that it is different, the way it's spreading and the way that the infection is attenuated in these individuals with probably better outcomes. So we're still waiting for a lot of data. We don't have seroprevalence data in Africa, because if we find that a lot of people have antibodies, that means that transmission occurred, but they just have a better immune system. On the other hand, if we find that the seroprevalence titers are low in the communities, it means that probably there are very, very intelligent public health interventions at the beginning of the pandemic, lockdowns, social distances, frequent testing, etc., were the ones that have minimized this, the aggressiveness of the pandemic. So there's still more to see, but I think these are important lessons that we should learn, and that I think are going to be very applicable to how we manage this pandemic in the next 2 years, because COVID's not going anywhere, and that's it. Thank you.
Thank you, Dr. Mira. I did want to point out, as I said, we have a lot of USET staff, and this is from the non-health side of USET. What you said about prejudices and African countries or developing nations, it's important to point out that oftentimes, even if they don't have an extremely technologically advanced medical system, that their public health system is often pretty good. And I think that this is kind of an example of that right there. With that said, I'll open it to any questions, especially amongst the USET staff, about what Dr. Mira said, or if you have any other questions for him to answer.
Yes, Christy, I couldn't agree more. Sometimes we associate high medical care to technology. And, I always tell my colleagues, yes, if I have a stroke, I want to be in the United States. But if I want to get control of my blood pressure or get a vaccine, I'd rather be in a third world country, because they have that probably better organized.
And for those of you who don't know, Gabby, who's new to USET, and I think most of you have met her on the staff meeting, she did some public health work in Haiti. And I know Dr. Brown, Dr. Brown, where were you in Tanzania? Where were you? He may have had to step off. I know he's at Cherokee working at the hospital right now, but he did public health work somewhere in Africa as well, public health clinical work. So you could probably ask them questions in the future, because they have a lot of interesting insight into developing nations' public health systems. And, it's the stories behind those that are oftentimes quite interesting, and not just dry, boring medical stuff. So anybody else have any questions or anything to say for Dr. Mira? Ah, there he goes. Cameroon and Nigeria, and he also did medical work in Panama.
Okay, if we don't have any other questions, we'll move on to Tori Reeves and Imani Ransby's presentation on the history of pandemics. Oh, Gabby does have a question.
I really wanted to be able to re-look through that. Is he able to send that PowerPoint?
I have it. I'll send it to you.
Okay, great.
We also record these sessions, and so they're on our YouTube page as well. But we can send you the slide deck.
Okay, thank you.
Okay, we'll move on to Imani and Tori.
Having a little issues trying to share my screen here. What I might try, either Brian, do you mind sharing them? If you can, it's not letting me. Otherwise, I'll maybe have to hop off and hop on because it's just not letting me.
Yeah, let me pull it up.
We've got David on here as well if we need some help, right? It seems like we ran into this before, and he was able to help us out.
Wait. Okay. I think, Brian, you haven't done it already, have you?
Oh, I was about to.
Okay, it's working now.
Okay.
Dr. Mira, before while they're working on that, let me ask you this. What are your thoughts about the vaccine timeline?
In what sense? Timeline?
Timeline for approval and for enough people in the US to get vaccinated to actually, make a significant difference in our numbers. I was kind of projecting end of next summer, but that's really just a guess.
Okay, so I think Dr. Brown's probably better prepared to answer this question. I'll just give you my 2 cents. When if and when the vaccine is approved, I'm going to take a deep dive and read the science behind it, just to make sure that I feel comfortable on the safety issues and also on the efficacy of the vaccine. Because sometimes you'll read a result, but then when you take a deeper dive, you start finding all these glitches on the study trial. Now, I'm pretty confident that I'm hopeful that won't happen and that the science will be solid. Just because they do it fast does not mean they cannot do it right, as long as they are very obsessive and precise about it. Now, the timeline, so it will depend, because if the vaccine that happens to work, then I know they've been fabricating a lot of vaccines, and we'll have millions of them to be delivered. But it's not going to happen overnight, just based on the flu experience. And so I think it's going to take a little bit longer than what they think. But as I mentioned, Dr. Brown probably knows more. He's been taking a deeper dive on the vaccine issues than I have, so I would rather have him give his input. It's probably better than mine.
Okay, yeah, I mean, Dr. Brown and I have been talking about this, but I just wondered if maybe you had a slightly different opinion or anything. Dr. Brown, if you want to care to share, just because I know you and I have talked about it, but maybe the rest of the USET staff and everybody else who's on would be interested.
Yeah, are you able to hear me? I'm on the cell phone.
Yeah, we can.
Hello? Oh, you can, okay. Yeah, so actually I agree with everything Dr. Mira just said. And as far as a timeline, I mean, you know, nobody has a crystal ball. My best guess is we may have a large percentage of the population vaccinated by next summer. That's if we get a vaccine that works pretty well. And again, you know, the vaccine doesn't have to be 100% effective. It just needs to be effective enough to stop the transmission from being out of hand the way it is right now.
Thank you. And also, we are about to have some documentation coming out regarding the flu and how important the flu shot is. So if you haven't gotten your flu shot, get your flu shot. Publix gives the free $10 gift card for your flu shot. So, or anywhere else you want to go. I won't plug Publix, but free for $10 is never bad.
Alrighty. Sorry about the technical difficulties there, and thank you, Brian, so much for sharing your screen. So with that, I'm just going to go ahead and get started and transition into our History of Pandemics presentation. I do want to note that we will not be providing an update on the COVID-19 Nashville area epidemiology as we usually do. We are currently working on updating those surveillance reports and graphs associated with those reports, but we will be back to our usual update next week on our echo. So just please keep that in mind. Next slide, please. So we've outlined some learning objectives listed here on the slide and feel that participants should be able to leave this presentation being able to define what a pandemic is and the difference between an outbreak, epidemic, and pandemic, discuss pandemics from BC to present, highlight the impacts of pandemics, identify the deadliest pandemics, explain the impact of vaccines, discuss the future of pandemics, new and emerging infections, and then also discuss lessons learned from the past. And I do want to note that, yes, we have included some polling questions throughout the presentation to just make it a bit more interactive. So you'll be seeing those throughout, and we're getting started with that right now. So we will give you just a couple of minutes to work on that. And the question is, what was the first pandemic? Okay. Alrighty. So it looks like mostly everyone got that, about 50%. But so the first known pandemic in history was the plague of Justinian, which occurred from 541 to 542 in the 6th century. I did think that one was kind of a little tricky because I would have gone for the Black Death just because that's what you probably usually think of when you think of pandemic, and especially the older ones. But and so Yersinia pestis, the pathogen that causes the plague, was responsible for this pandemic and an estimated 30 to 50,000 deaths. It started in Egypt, and it was transmitted by rodents with fleas that carried the bacterium. So that is thought to be the primary mode of transmission. In addition, this Justinian plague is also famous for being named after the Roman Emperor Constantinople, Justinian. And this pandemic was also believed to have led to the fall of the Roman Empire and is one of the 3 major plague pandemics that we've experienced through history. So it's the first one of its own. And I also do want to mention that Yersinia pestis is still endemic today in rodents, but has not posed a threat to humans as far as reemergence in the form of an outbreak goes. Cases can appear from time to time, but widespread infection like that of the plague pandemic is thought to be unlikely. And that's primarily due to advances in medicine, such as antibiotics and other public health advancements, including good hygiene practices. So, and then many may already may be familiar with this, but the bacterium also causes the buboes, the signature enlarged swollen lymph nodes that result from the infection. So if we could go to the next slide, please. So what is a pandemic? A pandemic is something that's declared when an epidemic spans over multiple continents and countries and the disease of concern has been widely spread geographically. Some examples of a pandemic include the current COVID-19 pandemic and then the Black Plague. And COVID-19 was declared a pandemic on March 11th, 2020, earlier this year, as many know, by the World Health Organization, and was noted as our first pandemic caused by coronavirus. So there were more than 118,000 cases in 114 countries at the time of that declaration. And the second example, the Black Death, which I mentioned, was the second plague pandemic in history, and arguably the most notable due to the social and economic shifts that occurred during and after that pandemic. Next slide, please. So just to differentiate between an outbreak, epidemic, and pandemic, we've listed some definitions here for each on the slide. And so an outbreak can best be described as an often sudden increase in disease cases that surpasses the normal expected number of cases in a geographic area or region. It's often used as a synonym for epidemic, but usually in reference to a more circumscribed or limited area. And outbreaks can present as a single case in an area where the disease is not endemic or occur regularly. So no particular case threshold is required to declare that. And just as a reminder, endemic describes areas where the usual circulation of disease occurs. For example, the flu we get annually, so that's endemic for the United States. And then, so we have the epidemic, and that is when an outbreak, an example, my apologies. An example of an outbreak would be the Ebola virus in Dallas, Texas, where the first travel-related case occurred, and then 2 subsequent cases were yielded from healthcare workers who came in contact with that initial case. An epidemic describes an outbreak that's expanded from a localized area to multiple areas within a city, country, or state. And an example of an epidemic is the hantavirus in the state of Arizona. And that occurred in 1993, where they were seeing pulmonary-like illness reported, and it was found to be hantavirus pulmonary syndrome and linked to an unknown type of hantavirus at that time. And lastly, a pandemic is just described as an epidemic that's expanded across countries and continents, and examples of that include smallpox and then the current COVID-19 pandemic. Next slide, please. So here we have another polling question. So where do most pandemics originate from? Alrighty, so where do most new pandemics originate from? For this one, I believe we said vectors. Vectors would be the answer, as they constitute living organisms that can transmit infectious pathogens between humans or from animals to humans. So we actually thought that that would be the best answer. And we have another polling question here. Who can name that pandemic? And what is this picture associated with? Alrighty. So the correct answer is actually the Black Death for that one. Again, the Black Death was caused by the bubonic plague. Whenever I see this image or similar ones, it somewhat creeps me out. But the story behind the beak-shaped masks are that physicians would wear these along with leather gloves and long coats to ward off disease and purify the air, and this led to their name of plague doctors. In addition, it was reported that they would also fill these masks with herbs and things like honey and cinnamon as well. And so I just want to briefly go over the differences between a plague and the plague to provide some clarification if needed, because it can get confusing at times. So a plague, it could have been, it can be, or could have been formally addressed as a group of diseases ranging from the measles to smallpox. Alternatively, the plague is the disease caused by the bacterium Yersinia pestis, which I have mentioned previously. And it also results in 3 types of clinical manifestations, including bubonic, septicemic, and pneumonic. So the bubonic plague is a result of an infected flea bite. The lymph nodes, again, will become buboes in that state as the pathogen will target the lymph nodes. And then the septicemic plague can result from untreated bubonic plague and will also or can affect a wide range of tissues and organs. Alternatively, this manifestation can also be the first symptom of the plagues. So that's important to keep in mind. And then the pneumonic plague is the only one that can spread from person to person via infectious droplets. It can also develop from no treatment and is noted as the most serious form of the plague. In addition, the plague could also just present as an acute or essentially asymptomatic state. Next slide, please. So this is just somewhat of a timeline for the pandemics that have occurred throughout time up to the present day. So you see the Justinian plague listed first there, followed by the Black Death, the sixth cholera pandemic, Spanish flu, Asian flu, Hong Kong flu, swine flu, and then COVID-19. And I think we may have missed inserting the third plague pandemic, because again, there were three major plague pandemics that occurred in our history. Next slide, please. So we have another polling question here. What am I associated with? Awesome. So it looks like a lot of people got that one. So this is a picture of the famous water pump on Broad Street in London. Many may know, but if not, John Snow is often referenced as the father of epidemiology. This is not the same John Snow from Game of Thrones, in case anyone was wondering. But John Snow studied cholera in his community extensively and is often revered for solving an outbreak of cholera in 1854. The outbreak was found to be sourced to the Broad Street water pump, which again was featured on that slide. Next slide, please. So now I'm just going to spend a little bit of time on the 1918 pandemic. The 1918 flu pandemic has been referenced as the most severe pandemic in recent history. Influenza A subtype H1N1 was the pathogen responsible for this pandemic, and an estimated 500 million people were infected when the number of deaths were at 50 million about. So it was associated with high mortality in the healthy, which was another reason why it's pretty notable, and specifically those aged 20 to 40 years old. Again, with no vaccine available or antibiotics during that time, public health efforts were pretty much focused on isolation and quarantine, good personal hygiene, and infection control. In addition, they kind of practiced somewhat of a social distancing situation, but it was not applied uniformly. They veered away from public gatherings, but again, it was not widely used. And so yeah, the first case was identified at Fort Riley Army Camp in Kansas. Just a bit more information on this slide if you're interested. So now we can go to the next slide, please. So now we're just going to take a closer look at influenza viruses just very quickly. Type A viruses can infect birds, swine, and humans. And the human subtypes that are documented include the H1N1, H2N2, and H3N2. In addition, types of influenza B and C have only been known to affect humans. You may recall that this past 2019 to 2020 flu season, influenza B, or the Victorian virus, circulated within the United States and actually accounted for almost 60% of the positive flu results. And this finding was interesting, as type B viruses haven't really been known to circulate at that level since 1992 or 3. Next slide, please. And so with this one, the main thing that I think I wanted to point out is that this graph shows the specific death rate by age, and I mentioned previously that those aged in the 20 to 40 age group seem to be most affected by this pandemic specifically. And so you can clearly see that here with the peak demonstrated on the graph. And with that, I'm going to pass it on to my colleague, Tori Reeves.
Okay, thank you so much, Imani. So we'll go ahead and transition over to another polling question. What country was COVID-19 first identified in? Thank you. Okay, thank you. And it looks like most people have responded there with China.
Tori, you're on mute.
Okay, thank you. So here we have the SARS-CoV-2 or COVID-19, which is the most recent pandemic, which is why we're here today. It has currently, right now, we're at about 102 million deaths worldwide. It's quickly growing, hopefully with the vaccine, the upcoming vaccines, and the continuing with the social distancing and hand hygiene, we can slow that down and, you know, keep that number from growing significantly. History. So first,
Tori, we're getting significant feedback from you.
okay. How about that? Is it better?
Perfect.
Okay, great. So we'll go ahead and start off with the Black Plague that had up to 200 million people that died across Eurasia and in North Africa. The pandemic spanned from
We lost you again, Tori.
in their family, so that hopefully doesn't continue to scare people. But just a little fun fact that the bubonic plague does live in Arizona, and it often resides in the prairie dogs. And sometimes we would see a die-off of like feral cats. And then during testing, they could test and extract, it would be the bubonic plague. So just a little fun fact for you that it has really not gone anywhere. It's still there. Our next pandemic is smallpox at 50 million, which is the second deadliest pandemic that we know. It peaked in the 18th century, and one good thing about the smallpox is if you did contract it and you recovered from it, you were immune. So that's one good thing about it. And thanks to vaccines, it is officially the one disease that has been eradicated from, the world. So we do not see smallpox, and it lives in a bio-level hazardous 4, locked away, never to see the light of day again. So our next pandemic is the Spanish flu, which Imani just touched on, which killed an estimated between 40 to 50 million people. It is the most recent pandemic and probably the best known pandemic in today's society, serving as a recent reminder of how far public health has came with all of the things that we've learned in the vaccines, has definitely curbed a lot of pandemics that probably could have occurred over the last couple of years. In 2018, it did mark the 100th anniversary of the Spanish flu. So they were trying to understand what made this strain of the flu so deadly. In 1997, a scientist extracted some very well-preserved genetic material from an Alaskan Inuit woman named Lucy. She did die in her mid-20s, and she was preserved in the permafrost, allowing them to extract that genetic DNA from her perfectly preserved lungs. So she played a major role in them being able to construct the genetic makeup of it and try to understand what made this strain, this avian flu strain, so deadly. And what they determined was the HA and PB1 genes in the virus played a major role in allowing it to be so easily transmitted. And then, of course, we have the plague of Justinia that Imani also mentioned, which killed up to like 50 million people, taking place in AD. So as the first known plague that we know so far, it was caused by the bubonic plague. And part of what allowed this plague to spread so rapidly and touch so many areas was war. The war that was going on, and then trade. So, next slide, please. So just thanks to COVID, we can see some of the impacts that occur as a pandemic, such as, we do see the widespread of morbidity and mortality, often the long-term effects that we see from COVID-19 right now, that people are recovering and no longer testing or testing positive, they're still having those long-term symptoms or complications like the shortness of breath and headaches, different things like that they're seeing lingering like weeks after they're told they're no longer infected with the COVID-19. Also, the economic damage that comes from pandemics, loss of work, it affects from top down, all areas, changing economic growth, and sometimes leading into a recession. There's also noted the increased fear and suicide rates that you may see, especially with the increased isolation because of the quarantine and just the severe changes in daily life. There's a significant social and economic disruption. So people don't, it changes, as you can see, it changes the way that everything operates, making family gatherings and the normal things taboo almost. There's also stigma and discrimination that is associated with people that contract the virus. You've seen a lot of things in the news that people talk about, hate crimes that have come up against the Asian population, just with the knowledge or lack of knowledge, discriminating against them, thinking that they are the reason that this virus is here. And then again, political stresses and tensions that tend to arrive just depending on how the government or leadership responds to the pandemic, how they provide support and mitigate the situation. As we are very well aware, it causes a lot of opinions to flare, disagreements to come up and stuff like that. So the best thing is to, have a unified front to fight that and, decrease the amount of stress that comes along from top down. Next slide, please. So, as Imani has mentioned, vaccines, antibiotics has been the biggest factor in curbing pandemics and helping to, really advance the population and society. So we go into our vaccines, the first appearing around 1798 and perfecting in 1935, which is smallpox, which currently is no longer in circulation, except for with like the military. And that's just due to the successful eradication of smallpox. So we have our more common ones: diphtheria and pertussis, tetanus, which is now combined in one, DTaP or Tdap. influenza, which started around 1945 initially in the military, making it more available in 1946 to civilian population, and then increasing the surveillance, showing that each year that the strains of influenza does change. So they are, each year we do receive a different quadrivalent or trivalent influenza vaccine based off of last year's strains that were going around, and then just like as a way to kind of predict it. So with the quadrivalent, there is that more chance, higher chance of, you know, getting protection than the trivalent because it has more strains in there. And then the polio vaccination. Next slide, please. So then we have our normal childhood immunizations, which we are familiar with: measles, mumps, and rubella, MMR, hepatitis B, which is, you know, typically your first vaccination, one of the first vaccinations, H influenza type B, and then which is Haemophilus influenza, and the varicella, which is the newest one, as well as hepatitis A. Some of these are live vaccines, and then some of them are attenuated, so it does vary when you will receive them. CDC does have a timeline with the recommendations on when you should receive them based on age, which type that you receive, and things like that. So all of the things that have come along with the vaccination development has significantly played a role in pandemics and outbreaks, as well as just really showing us how far public health has come and how fortunate we are. So next slide, please. So we have another polling question. What public health measure has made the significant impact on decreasing epidemics and pandemics? Let's not answer all at one time. I know it's a super exciting question. Okay, thank you, Brian. Okay, so it looks like we have some mixed answers. We have some hand washing, development of CDC and vaccines, but the response, the correct answer is vaccines. They, like I said, they have made the biggest significance here with, you know, in public health. It's the biggest measure in decreasing those virus outbreaks and things like that. So next slide. So the future of pandemics, we, as an epidemiologist, just constantly thinking that what is going to be the next outbreak, what's going to be the next pandemic. I don't think anyone would have suspected it to be a SARS virus, but here we are. So we've heard conversations about influenza with the suspected avian flu, floating around again, H1N1, or possibly a zoonotic disease happening, or bloodborne. You know, like the most recent one, bloodborne pathogen that we know about is HIV. You know, and that epidemic is still going on. It's all across the world, and we have this current administration's ending the HIV epidemic to you know, focus on that to hopefully end that. So next slide, please. So history, it serves as a purpose. It serves a purpose. It can teach us lots of things. It can show us how people have responded in the past, how, you know, what worked, what didn't work, what systems we need to develop, and technologies that we need in order to fight the unseen world, the microbial world. It also lets us know that any pandemic can come without a warning. I don't think when the first case in the United States happened, none of us was expecting, you know, to be quarantined and stuck in a house 7 months later, or for any of our lives to be, you know, just changed around like this. So, you know, anything can happen at any different time. Next slide. And that is all that we have today. Hopefully you learned lots about pandemics and you're super excited about them like we are. If you have any questions about pandemics or anything that we can assist you with, please reach out. If you also would like a RECAP account, you can also reach out to the USET Tech COVID-19 surveillance team or the epicenter. And here's our contact information here. Thank you.
Thank you, Tori and Imani. That was very interesting. I appreciate that. Of course, you know, this is our passion, and I'm glad that we're able to share it with other people. We're a little bit over from what we normally are. So if there's not any questions, we'll go ahead and drop off. Does anybody have anything for Tori and Imani? Dr. Mira has a hard stop at noon, so he's already dropped off, but Dr. Brown is on, and he may be able to answer some of the questions that if you have any for Dr. Mira.
One quick thing, if you're searching for credits for continuing education, make sure you fill out the survey link in the chat box. Even if you're not searching for credits, you can fill out the survey, and that would be helpful for us. I don't have anything. Have a great rest of your Friday. Bye, everyone.
Bye. Thanks, Brian.
Thank you.
Mhm.